Welcome and thank you for inviting me to come and speak to today's conference. I am a specialist paediatric dietitian at Manchester Children's Hospital, and I'm going to cover the management of common infant feeding conditions in primary care and when to refer on. So I'm going to cover about identifying the difference between lactose intolerance versus cow's milk allergy and other common infant feeding problems such as colic and reflux. We'll also look at eczema management and when is it just eczema and when is it cow's milk allergy and how you would confirm a diagnosis. I'll also look at how to continue and support breastfeeding with cow's milk allergy and how the infant outgrows the allergy and at what age to reintroduce milk. So the prevalence of functional GI disorders in infants is actually quite high. Approximately 50% of infants between 0 and 6 months will show some signs or symptoms of at least one functional gastrointestinal disorder. The most common one we see from early on is infantile colic, between 5 and 20%. And this is one of the most distressing ones that parents report due to the infant being really young and post-birth and lots of hormones and really there being no resolution to the symptoms other than allowing them to outgrow it. Regurgitation or gastroesophageal reflux is the next one that you would see, between 30 and 67%. And often there's a crossover with some of these symptoms and cow's milk allergy. So it's really knowing when is it just reflux and when could it possibly be a milk allergy. The other functional GI disorder is constipation. You do get soft stooling constipation with cow's milk allergy. So that is something to bear in mind when you're assessing symptoms of an infant and perhaps they have reflux, blood in stools or eczema, as well as soft stool constipation. And then the last one is cow's milk allergy. Once you've ruled out or managed the other functional GI disorders, it's worth considering cow's milk protein allergy. I think there's often an overestimate of symptoms, and parents now will use a lot of Facebook groups or kind of word of mouth and will assume that their infant has a milk allergy. As you can see, the actual prevalence is quite low, at between 2 and 4%. So it's really important to confirm a diagnosis of this rather than putting them on a specialist milk or excluding milk from mum's diet and the infant's diet when it might not be a confirmed milk allergy. So case study 1, a 6-week-old infant. This is a first baby, fully breastfed for 4 weeks and started formula at night 2 weeks ago, and has had occasional formula within the day. Mum reports that he's constantly crying and screaming and keeps waking in the night. So at this point, what else would you like to know? So it's important to take a full history, and it's noted that the screaming is much worse in the evenings. The sleep is within normal parameters for a 6-week-old, and there's no family history of atopy, no eczema, no rashes, or no other signs of anything to exclude milk allergy. So at this point, what would you do next? It's likely that this infant has infantile colic. So what is colic and what does it stand for? So colic actually stands for cause obscure lengthy infant crying, and it presents as accessible inconsolable crying and limb flexure. It's most common in the late afternoon and evening, and it should follow the rules of 3. It should last for greater than 3 hours a day, more than 3 days a week, and it should have been occurring for a minimum of 3 weeks. It isn't when they're just upset or hungry for just a few hours in the day. This is really important to make sure you're getting a full history of how long and how often this is happening. Unfortunately, it starts in the first few weeks of life and usually peaks around 6 weeks of age. It will settle between 4 and 5 months of age, but often parents want an answer straight away, or they feel like they've done something wrong. And it's important to note that this is in otherwise healthy, well-fed infants. So what it isn't is a couple of hours of them being uncomfortable or discomfort that might be associated to wind. But it is perceived by mothers to be one of the most common problems, and it can lead to a lot of anxiety. So the management, the general advice is a lot of hand holding and support for parents, and it's for helping them to look for signs of hunger and fatigue and to establish a regular feeding and sleeping pattern, at which point they can assess cues for feeding and hunger, and the infant, will be in a routine. A lot of it is reassurance that it's not their fault, it's not harmful to the infant, and they will grow out of it and it will get better. It can be important to look at how much they're feeding, if they're latching onto the breast appropriately and not guzzling lots of air all at once, which can make symptoms worse. So the second case study is a 3-month-old infant presenting with choking and vomiting on feeds. They've had standard formula since birth and has always been quite a fussy feeder with the bottle. They're now starting to turn their head away and refuse milk and bottles quite frequently. They also note to cry a lot. They're generally unsettled, and there's a lot of back arching and distress when lying down. So what else would you like to know? I guess there's no family history of atopy. The length and head circumference continue on the 25th centile, but the weight has fallen to the 9th centile. There's no eczema or rashes, but there is back arching and screaming after feeding. So what would you do next? It's likely that this infant has gastroesophageal reflux, which again is common in infants, up to 67%, as we saw from the first slide. And this is when the regurgitation of the stomach contents comes up into the esophagus. And it is mainly if they're feeding large bottles or gulping lots of air, because their tummies are only actually really quite small and as kind of small as their own fist, really. So if it's important to assess how often they're feeding and what volumes. It's because the infants at such a young age have an inappropriate opening of the lower esophageal sphincter. As you get to adults, this closes and opens more frequently to keep the acid and the food in the tummy, but this hasn't yet formed in infants this young. 50% of infants will regurgitate at least once a day, and this will generally resolve by 12 to 15 months of age. But there are more severe forms that don't respond to simple treatment, and they develop gastroesophageal reflux disease. The symptoms to look out for: crying during and after feeding, pain that's associated with feeding, and a feeding aversion, so starting to become fussy with the bottle and not taking food or milk as they normally would. They can vomit. Sometimes it can be projectile, it can be occasional, and as the symptoms get worse, it would be after every feed. On the more severe spectrum, because they stop feeding as well and they're vomiting more, you get the associated poor weight gain and the growth starts dropping off the centiles. So gastroesophageal reflux disease, it's acid-induced lesions of the esophagus, and the esophagitis starts to develop. And these are the more severe forms that perhaps would need more tertiary or secondary paediatric input for support. And it can be associated with failure to thrive, vomiting blood, and respiratory symptoms. And often these may need NG or NJ feeding to allow things to settle down until they've outgrown some of these symptoms. There is an element of gastroesophageal reflux that can be secondary to a food allergy. And at this point, it's important to look at the other symptoms that might be related to a food allergy, and then to possibly try on a cow's milk-free diet or an extensively hydrolyzed formula. So the advice for gastroesophageal reflux, again, as with colic, a lot of parental reassurance. Positioning is really important, and avoid any positions that exacerbate the situation. For example, lying down after a large feed, jumping up and down on someone's knee, and it's important to keep them on a slant when actually feeding, 30 to 45 degrees if appropriate, and particularly after a bottle to allow the milk to go down. It's important not to overfeed, and this is sometimes difficult when they're breastfed, as they respond to hunger cues And it's important to make sure that they're latching on and the supply of breast milk is adequate so that they're not gulping lots of air, which again can make gastroesophageal reflux worse. If they are formula fed, more smaller and frequent feeds are more beneficial. Parents are often really keen to get infants onto 4-hourly feeds or to avoid feeding them overnight. But that then has a knock-on effect that they're having large volumes of milk in the day at once. The next step after that would be looking at thickeners or pre-thickened formulas, and things like Gaviscon that you can give alongside breastfeeds or added into milk. So what does the guideline say? I guess we've got the NICE guideline from 2015 and the more international one, the NASPGHAN and ESPGHAN from 2018, that again recommend parental education and reassurance around feeding as the first line, and support for them to understand that some of the symptoms can be normal. If they are breastfed, continue and support with breastfeeding as much as possible, and ensure that they are have enough supply and the latch is appropriate, and perhaps offer some breastfeeding assessment to see if there's anything that can help with that. And this is really, I think, to avoid parents giving up on breastfeeding, which is so beneficial for the infant, and to support them to continue as much as possible. If the infant is bottle fed, reduce the volume and avoid overfeeding. So between 0 to 6 months, I guess we estimate about 150 ml per kilo. It's not always as measured out in the community, but you might find that those suffering with gastroesophageal reflux might be on 200 ml per kilo, and that there will be a reason why they're vomiting, because they're having large volumes of fluid into their tummy that is very small. It's important to look at positioning, supine for sleeping, elevate the head when they're feeding and awake, and supine for sleeping only. The next step would be to look at thickened formulas or adding a thickener for breastfed or bottle-fed infants, and alginates can be first line if breastfed according to the NICE guidelines, but if there's a couple of weeks trial and there's no response, then that could be stopped. So thickeners, you can get an instant thickener that can be added into a standard bottle or into express breast milk, or given alongside, and you add a small percent, so it's normally about 1%, which is a scoop from the box that you get, and this would be gradually increased. This can be used if the infant is severe gastroesophageal reflux and requires nasogastric feeding, but be wary that obviously thickeners can block the tubes as well, so this should only be done under the guidance of a dietitian. So if at this point you've tried all the first line recommendations, the NICE guideline at this point recommends a 4-week trial of gastric acid inhibitors. And I think we're trying to steer away from using too many medications first line, whereas the more recent NASPGHAN and ESPGHAN guideline at this point would consider a trial of milk protein avoidance if the infant is symptomatic and breastfeeding, to consider excluding dairy from mum's diet as a trial. And if the infant is formula fed, then consider extensively hydrolyzed formula, again for a 2 to 4 week trial, followed by a reintroduction to assess if this has helped with the symptoms. After this point, then it may be appropriate to refer into a paediatrician or in a secondary or tertiary care for further ongoing support. So the medical management that we've touched on, I guess you've got your Gaviscon, which can often cause constipation, and sometimes parents don't find it really helps significantly, and again then has the knock-on effect of them not being able to pass stools. Your proton pump inhibitors are your omeprazole, and this works in a way of inhibiting the gastric acid secretion. And you've got your prokinetic agents such as domperidone, which can elevate the esophageal sphincter pressure and stimulate gastric emptying. It is to be used in caution, and a lot of these will need an ECG before or an echo before starting this medication. We don't use erythromycin and metoclopramide that often in infants, and definitely not first line, but this would work in stimulating the gastrointestinal motility. So case 3, a 9-month-old girl, well until severe diarrhea and vomiting illness 4 weeks ago. And actually brother had the same diarrhea and vomiting bug. But however, the diarrhea has continued to be ongoing, and she has a very sore bottom, very miserable and very poor sleeping. And as you can see, her bottom is really red and sore from the stools that she's passing. So what else would you like to know? The brother had a milk allergy in his first year of life, but milk has successfully been reintroduced at 14 months. They received standard formula from birth, no signs of gastroesophageal reflux, generally thriving along the centiles, and no eczema or other signs of atopy. So what would you do next? It's likely that this child has a temporary lactose intolerance post GI bug, and that is really because the lactase enzyme lives within the gut wall, and if you've had a bug or an infection that's affected the gut wall, then your lactase enzyme is in less quantity and therefore can't break down and digest the lactose in the formula or the breast milk. At this point, it would be a trial of lactose-free formula, and again seeking support from breastfeeding experts and your infant feeding teams if you're breastfeeding, to try and lower the lactose load in the breast milk. Again, this should be a 2-week trial, and if it improves the symptoms, then continue for this for 6 weeks. It's not a long-term avoidance, and then a slow reintroduction back into the diet as the gut wall heals and the lactase enzyme replenishes itself. There's no long-term avoidances that should be needed. If after this trial there's no improvement, it's definitely worth considering other causes, for example, cow's milk allergy, and trialing an extensively hydrolyzed formula to see if this helps with symptoms. Case study 4, a 6-month-old boy, breastfed, history of reflux, eczema, and generally unsettled since 3 months of age. He was given top-up formula from 3 weeks ago and started to develop blood in the stools over the last 2 weeks. So sometimes it's really difficult to know if it's a lactose intolerance or a cow's milk allergy, as a lot of the initial symptoms are very similar. For example, the loose, watery, frequent stools, your abdominal pain and distension, wind, and your nappy rash. But with the milk allergy, there's another list of atopic symptoms that is important to assess. For example, it's common to get mucousy or blood in the stools. They're generally quite offensive in smelling and appearance. You can get soft stool constipation where the infant is straining and then passes a watery or loose stool. They may have a history of gastroesophageal reflux or projectile vomiting. They may have poor weight gain, or similar with the gastroesophageal reflux case, is start refusing food, feeds, and the breast if it's causing them discomfort. There may be a history of atopy in the family, or a family history of milk allergy, and the infant also may be suffering from eczema. So if any of those secondary symptoms are presenting, it's always worth considering a milk allergy. So when we talk about food allergies, we talk about food hypersensitivity. So food intolerance is where the immune system is not involved. And this is the lactose intolerance that I was previously just talking about, where the enzyme lives within the gut wall and the immune system is not involved with the intolerance and the symptoms. And then you have your IgE and your non-IgE food allergy, so what we call delayed and your acute symptoms. And often the delayed symptoms are classed as an intolerance, but actually we would class it as a non-IgE food allergy, as the immune system is still being involved. It's just a different mechanism to your acute IgE reactions. So the Basaki and the World Allergy Organization state that cow's milk allergy is a reproducible adverse reaction, and it's of an immunological nature that is induced by the protein in cow's milk. So it should happen on every exposure, and it's using the immune system and can present with a variety of symptoms. With testing, which is often what parents want, skin prick tests and specific IgE blood tests are only helpful if they've had an acute or immediate IgE food allergy reaction. They are not helpful if they are delayed and non-IgE, and they would only be about 70% accurate alongside a detailed food allergy history. So it's important to actually note that food avoidances and challenges are much more accurate than any tests that are often requested. So what is cow's milk allergy? It generally presents in the first year of life. Estimated prevalence on the higher end between 2 and 8%, but often between 2 and 4, 2 to 6% most commonly. There is an overestimation of cow's milk allergy, and a lot of parents assume that they have cow's milk allergy, whereas they might just be suffering with reflux or colic. It is often difficult to diagnose, particularly the delayed non-IgE allergies, because there's a wide variety of non-specific symptoms. And often they may have these symptoms that parents perceive as being normal until somebody assesses the full range of the infant symptoms to actually consider whether it's a milk allergy. It's often the non-IgE delayed allergies that have the most frequent GP visits and health visits to assess symptoms before they actually get a diagnosis. And this can cause a lot of infant and parental distress and anxiety, to the point where it starts affecting growth. That is, I guess, another concern, as it's really important for infants to continue to track along their growth centiles. So the symptoms can be immediate, which I said before is IgE mediated using immunoglobulins, and they can be delayed, which uses the T cell mediated mechanism of the immune system. You can also get a mix of IgE and non-IgE, and avoidance for long periods of time has seen non-IgE symptoms change to IgE and vice versa. So avoidances should be managed with dietetic support and reintroductions done in a timely way. So the best way to diagnose a cow's milk allergy, the gold standard way, is eliminating the milk protein from the diet, followed by a challenge. At this point, you would hope that symptoms resolve, and then by exposing them to the milk protein again, the symptoms are replicated, and this is what confirms your diagnosis. 2 to 4 weeks avoidance should be done to allow any inflammation or any symptoms to settle down, followed by the reintroduction. And this is for the non-IgE mediated milk allergies. If you've had an infant suffer with what you assume is an acute IgE, where any wheeze or cough or breathing difficulties, you would not do the elimination and the challenge in the community. You would eliminate the food and look at the reintroduction under a management plan and team at a later date when they've likely outgrown it. So diagnosing the milk allergy, the detailed food allergy focus history is the most important, excluding all milk protein in the diet from either the formula, and if the infant is weaning, making sure there's no hidden sources in any of the foods that they're having, followed by a challenge to confirm the diagnosis. Any high risk or severe reactions, then re-challenging this at home is unsafe, and we would normally advise continuing to exclude the milk protein until at least 6 months of being symptom free, and consider sort of challenges in the hospital for those more severe reactions, or look at the milk ladder under a management team and an allergy service. Skin prick tests and blood tests are only helpful in these immediate IgE symptoms and should only be done in combination with a full history and challenge. It's not helpful to do a full panel of specific IgE blood tests for all the different food types, particularly if the infant is still only on milk or breast milk. And it should only be done specifically to a food group following a reaction to that food protein. The GI manifestations, particularly in the delayed milk allergy, will likely have negative skin prick tests and therefore not helpful at all in a diagnosis. So how do you manage a cow's milk allergy? 2 to 4 weeks of a milk-free diet If no improvement, then it might not be that that's the diagnosis. But if there is an improvement, then continue with the extensively hydrolyzed formula. We normally use an EHF first line, particularly with 90% of infants, and only those with the more severe or multiple food allergies we would use amino acid formula with. It's important to note that soya formula should not be used first line, but is there as an alternative if you're struggling to get the infant to take an appropriate extensively hydrolyzed formula. We do, however, note that up to 50% of infants with non-IgE delayed milk allergy may also be sensitive to the protein in soya, as they're quite similar in structure. Breastfeeding should always be encouraged to continue, and avoidance of milk from mum's diet only if the infant is symptomatic through mum's breast milk. If, for example, the infant has had a formula or started weaning and had a reaction to the food or the bottle, but previously tolerated mum's breast milk fine, I would always advise mum to continue with milk in the diet, as the infant isn't symptomatic, and this can allow tolerance and help them outgrow it quicker for the future. It's important to always ensure that breastfeeding mums are taking appropriate vitamins, particularly of calcium, up to 1,000 and 1250 milligrams for mum, as well as vitamin D. And it can be noted that infants will be sensitive to other milk proteins, so it's not appropriate to give them other mammalian milks, for example, goat, buffalo, or other mammals, as there's a cross-reactivity. So supporting mums with breastfeeding. Avoid the milk allergens only if they're symptomatic, and do this for 2 to 4 week trial if indicated. This is because there's a nutritional risk for mum and the infant. The infant will generally take all the nutrition that they need off mum, but it's important for bone health that there's appropriate calcium and vitamin D in both of their diets. I would always avoid any multiple food avoidances, as this then restricts mum's diet even further and it affects her nutrition as well as babies. If mum is continuing breastfeeding but might need a extensively hydrolyzed formula for weaning or to add into any foods that they're making, this can be offered as well. But the breast milk should continue as a main drink as well as the weaning foods. So if they're on formula, which formula should they use and when? Extensively hydrolyzed should be suitable for up to 90% of infants. There's a whey-based extensively hydrolyzed formula which contains lactose. This is generally more palatable, and we know that lactose aids calcium absorption within the body. You've also got casein extensively hydrolyzed formulas which don't contain lactose. This can sometimes be beneficial if they've had GI symptoms, for example, blooded stools, where there's some active inflammation within the digestive system. The second stage formula contains fructose, which then aids palatability, normally once they've already started weaning and are a bit more fussy with taste and bottles. So the amino acid formulas are there for 10% of infants that have severe symptoms. They don't contain any lactose and are completely hypoallergenic. Soya formula could be used over 6 months of age, but not first line. And there is a chance that the infant will have a cross-reactivity to the protein in soya. So this is a picture format of the extensively hydrolyzed formulas and the amino acid formula. If you see the intact proteins are what would be in your standard formula of quite a complex protein structure. Your partially hydrolyzed are like your comfort milks and your reflux milks, where some of the peptides, some of the protein has been broken down into smaller peptides, but would not be suitable for an infant who's got a diagnosis of cow's milk protein allergy, as they will still react to those bigger chains of protein. Your extensively hydrolyzed, as you can see, the peptide chains are much smaller than the partially hydrolyzed, and this should be suitable for 90% of infants with a mild to moderate cow's milk allergy. The final formula is completely hypoallergenic, and this is your amino acid formula for the more severe milk allergy infants. So practical tips for introducing a new formula. They do taste and smell different. It's usually not a problem for younger infants, but if it is troublesome, then to introduce this slowly. And try not to keep changing formulas. It can take several weeks to actually establish them on a new formula and allow symptoms to settle down. I think parents often want a quick fix and expect after 24 hours that they should be taking it and symptom free. If the infant has mild symptoms of milk allergy, you can titrate this with their current formula to allow them to get onto the taste. But the longer you continue to expose them to milk protein, the longer it will take for symptoms to settle down and then to be able to be 6 months free of symptoms and reintroduce as per the milk ladder. It is important to note that the stools will change due to the protein structure that is different in the extensively hydrolyzed formula. They generally change in consistency and in colour, which tend to be a dark green to black colour. So it can take up to 6 weeks to see complete symptom resolution, and that's why I'd always encourage parents to persevere for at least 2 to 4 weeks to allow symptoms to settle down. If they are consuming 500 to 600 mils of formula a day, then no vitamin supplementations are needed, as that is nutritionally complete. If they're taking less than that, perhaps they've weaned off breast milk and are a bit fussy with the bottle and the taste, or they're over 6 months. If they're not taking that volume, it's worth reaching out to a paediatric dietitian or infant feeding team for advice on appropriate vitamin supplements. You can maximise the intake, particularly if the infant is of weaning age, by using it in cooking, using in family meals, making custards out of it, and using for sauces in things like pasta and rice. But potential hurdles, I guess the delay in diagnosis can often lead to a lot of anxiety. And this parental anxiety can relate to the infant and cause more fussy feeding and feeding aversion, but this is more strongly associated with reflux symptoms that have not been managed appropriately. With eczema, I think it's easy for parents to start taking multiple foods out, and as I'll talk shortly just about eczema management, is that actually it's really important to get the eczema under control and continue to introduce a large variety of foods into the weaning diet. Ensuring both mum and infant have calcium and vitamin D. Soya introduction is helpful as a calcium and protein source, but like I said, some infants will react to soya. I would, however, not avoid it unless a symptom had occurred. And breastfed infants transitioning to a bottle, whether mum's going back to work or is keen to kind of wean off the breastfeeds, this is often the most challenging part. And I do encourage parents to perhaps express breast milk at a younger age to get them used to having a bottle, so this stage is easier. So weaning, breastfeeding should continue. All low allergenic food should be given before 6 months. Only low allergenic food should be given before 6 months, for example, fruits and veg. But we know that actually the early exposure to high risk milk proteins from the LEAP study, particularly with peanuts, actually if you expose them at an earlier age, they're less likely to develop food allergies in the future. So we're still sitting on the fence with regard to doing this under 6 months as per this research study, but definitely from 6 months we would, even if they were milk allergic, we would still move forward with introducing all the other food groups one at a time. If they're still needing a milk avoidance over 1, you can either continue breastfeeding. There are infant formulas that you can continue, for example the extensively hydrolyzed formulas, and amino acids are suitable up to 2. And then you've got your shop bought alternatives, but it's important to check that these have adequate protein, calcium, iodine, and vitamins in. So always to seek advice about this from a health professional. Ensuring a nutritionally complete diet is important. We've touched about calcium, but also that infants up to 2 years need a full fat diet and plenty of protein, particularly iron, as their iron stores start to deplete from 6 months of age. All infants that are breastfed need vitamin D supplementation, and those moved on to a shop bought alternative will need vitamin D supplementation. If an infant is taking 600 mils of formula a day, then they would not need any additional vitamins. So lastly, just to touch on eczema, there's a lot of confusion about eczema and food allergy, but what we do know is that eczema is quite common, affecting lots of children in the UK, and more commonly around elbows, wrists, knees and ankles, and it generally starts in the first year and improves with time. The diagnosis, however, is made on symptoms and appearance rather than tests. And it's actually really important to note that eczema is due to a skin barrier being leaky, where the skin becomes dry and gets exposed to other environmental factors where it becomes inflamed. It's not necessarily linked to the immune system and causing further food allergies. The main treatment is regular moisturizers, really to help protect the skin barrier, because exposure of other proteins through the skin has shown to lead to food allergy at a later date. So it's important to maintain the skin barrier with plenty of moisturizer and emollients and continue weaning orally as normal. So antihistamines don't really relieve the itch and the eczema, as it's not the immunoglobulin mechanism. Changes to the diet of growing children should be taken lightly. This can affect, obviously, if mom's breastfeeding her own diet, but also it's more likely in an atopic child to increase their risk of developing food allergy in the future if unregulated foods are avoided from the infant's diet. And actually, the early exposure to milk proteins orally, and given orally, not in the environment or on the skin, can help them prevent a food allergy in the future. And this is really linked with the allergic march, in that actually the eczema, which is the skin barrier defect, they can be exposed to things through the skin where it's irritated, and then when you're given it orally can stem to a food allergy. So it's really important to get on top of the eczema management first to avoid the food allergy. And then as they get older and school age, things like rhinitis and asthma will again develop in these atopic children. So if it is a milk allergy, I guess when do we want to reintroduce this? We know it's not forever, and actually avoiding it for too long is more likely to lead to a more severe allergy or mean that the infant won't take the milk at their older age. So the guidance says this should be done at 12 months of age, and if there's been no reaction and they've been symptom-free for the last 6 months. It may be that they've had contact with dairy-containing foods and they've been okay. So from doing a history, they might have had siblings' chocolate buttons and been absolutely fine. And that would be your insight to then start with the milk reintroduction process. It's important to try and normalise things as soon as possible and wean them off the infant formula. For example, if they've been on a hypoallergenic amino acid formula, stepping them down to an extensively hydrolyzed can again help improve their tolerance as they're being exposed to bigger chunks of peptides. If they've been transitioned onto a shop bought alternative, if they're over 1 and the rest of the diet's adequate, this again is a step forward. It's being active in our allergy management. And this is really important to make sure they've got support from an educated health professional and a dietitian on this to ensure there's no nutritional inadequacies. So this just shows you the milk ladder, which is from the IMAP guidance that was updated in 2019. The very original MAP guidance from 2013 had 12 steps in the milk ladder, but this is a more simplified version. And it really takes you through the steps of reintroducing milk back into the diet in a more quantified measure. And this exposure of the milk protein that's been built up is actually allowing the body to start to tolerate it in a step-by-step way. So in summary, the early diagnosis of a functional GI disorder is key to support parents and reduce the impact of anxiety, and also to help reduce the infant symptoms. It's important to optimize eczema treatment and reflux symptoms as soon as possible to avoid things like further food allergies or food aversions. It is important to consider a cow's milk allergy, and if it is thought that this is the diagnosis, then a 2 to 4 week trial of elimination followed by a challenge if it's safe. Breastfeeding should always be supported and continue, and again ensure that mum and infant's diet has adequate vitamins, and only avoiding dairy if the infant is symptomatic. Support for parents should be there if they're wanting to use a specialist formula, or step down from breastfeeding. And I would say 90% of infants will tolerate an extensively hydrolyzed formula. Milk-free weaning advice, I guess the key thing is avoidance of milk, but also not to delay introducing the other food groups into the diet to prevent further food allergies, and being active, so not leaving that infant on a milk-free diet for too long, is constantly trying to see how can we improve and normalize things for this family as soon as possible. Thank you very much for listening. I do work in the NHS full time, but I also see patients in my own time and do a lot of teaching. If anybody would like any further information, then please contact me on any of these social media or email, and there's my website as well. Thank you for listening. I'm happy to take any questions.